Okay, let's get started. I've been asked to talk about care during COVID-19 and about communicating with your patients about COVID-19. These are just some tips. You have many as well, so we look forward to hearing about what you've been doing during this time. Here are my disclosure slides. And here are several ways that we mitigate potential biases. And in this presentation, I've used evidence-based material, and we do in all of our presentations. In terms of learning objectives, I wanted to review how to start the conversation with patients about COVID-19, and I'm going to maybe use my practice as an example, review various COVID-19 assessment tools, and then review what are the most important points to leave patients with. While preparing for this talk, I was perusing the internet like many of you probably have, and I found that there were so many excellent care resources on how to conduct virtual care. Terry actually spoke about many of them, how to carry out in-person visits during this time, and information about COVID-19 itself. And I'm going to go into a few of these in a bit more detail during my talk. So I put a star there to remind myself to maybe explain what my practice is like. I'm a infectious disease specialist, but my main work is in HIV and hepatitis C. So the majority of my work is actually as an outpatient with outpatient visits. And I have converted to telephone visits and virtual visits. And so I'm going to be talking from that lens. And I'm sure many of you saw that the OMA put out guidance on how to carry out virtual visits and documentation of such. And they recommend first starting with establishing and confirming the patient's identity and location, and for example, confirming their date of birth. The other thing that the OMA has said is important is to get patient consent for the virtual visit and to document that. And in fact, they've come up with a short paragraph that they've vetted with the Ontario MD legal team and the CMPA, and it's up on their website. And this is the version I use of that. So in my patient notes, I write, this patient visit was conducted by telephone instead of in person due to the COVID-19 pandemic. Informed verbal consent was obtained from this patient, and so forth. And you can see. And these slides will be up there. If you don't have such a statement, feel free to copy and paste and use this for your notes. The OMA has also asked us to timestamp our visits with the start and stop times. And I found that it is important to start all my visits, even if it's regarding another topic, with checking in about COVID-19. It's a little bit like the elephant in the room with all patients. Sometimes I don't use the term COVID-19, I just say coronavirus because it might be easier to understand, but asking them, are they staying home? Or do you understand how important physical distancing is? And I kind of prepare them that the physical distancing is likely to go on for at least 2 months, if not longer, and that it's important to limit leaving the house and doing so only for groceries. Maybe going to the pharmacy to pick up medications, but many pharmacies are delivering now. In my patient population, food security is a big issue, so I ask them, do they have enough groceries? Do they have enough money? If they say no, I have an excellent nurse I work with, and I can set up an appointment with her who can spend more time trying to figure out how to connect patients with resources. I've asked them, do you have or have you had any symptoms of COVID-19 and any questions about it? And I also consider other items like, do they have any risk factors? What I've noticed is the questions are starting to shift about COVID-19 from my patients. They're asking, how is Ontario doing? How is Canada doing in terms of COVID-19 and physical distancing? And so I added these slides, this slide kind of last minute, because it helps answer this question. This first graph is from Public Health Ontario. and it's for the different regions in Ontario. And as infectious disease specialists, we talk about the infectivity of an agent by its reproductive number, which is here on the y-axis. And at the beginning of the outbreak in Ontario, the average reproductive number was 3.5. So that means that for every person infected, there would be 3.5 people infected. And the goal out of controlling an outbreak is to get that reproductive number down to 1 or below 1. And you can see that over time, we have done that in Ontario. So the physical distancing is working. And then this graph on the right is the modeling that Premier Doug Ford presented on Monday. The red line is the most important line showing our current ICU capacity. And the goal of physical distancing is never to surpass that line. And in pink is what's happening in Ontario. And in fact, the projected use of ICU beds and ventilators is lower than expected. And so this is proof again why physical distancing is so important and that it is working. And I reassure my patients of that. Next, what do? I kind of tell them, we're here to talk about a regular visit about HIV, for example, and we're going to go on and do that, and we're going to review this, that, and HIV care. And I go through my regular visit, and then I make a plan for my patients for the next 3 to 6 months. We've been delaying blood work, so if blood work is not urgent, I'm telling them, maybe we'll do it in August or September. And then I ask them, how often do you want to follow up by phone during this time? And I have found that people want to touch base by phone more often than they used to, and you're probably seeing the same. If a patient does have to come in person, the nurse I work with works 1 full day on Wednesday, and I'm working Tuesday mornings to see patients, and we are booking patients 30 to 40 minutes apart so that there's only one person who's in the office or waiting at a time. We put an X on the floor where they stand. I ask them to wear a mask if they have one to come in, and if they're coughing, we give them a mask if they don't have one. And if they have to do blood work, I get consent to either email them the blood work rec and also walk them through how they should be going to the lab, or some labs, or in my EMR system, I can fax the lab rec directly to the lab, or if they have to come up, pick it up in person, again, I walk them through how to do that. I find that it's really important to always end with compassion, saying something like, if you have any issues, our admin, our nurse, and myself, we're here for you. Just give us a call. And then, of course, document everything. This website and group, Vital Talk, has a whole bunch of great information. And they have this acronym of how to carry out a virtual visit in the COVID-19 era called Calmer. And it turns out, I think that I'm actually using this method and I didn't even know it, but it starts with checking in. So checking in with the patient, then ask about COVID, lay out the issues, motivate them, expect emotions, and record the discussion. And then they have another acronym named SHARE, and you can get more details from their website there. Okay, a little bit more about COVID-19 itself. I think in the chat there, Jing was saying how they were helping out on the phone with 50,000 phone calls. I think one thing that's really important to understand are the Ontario testing guidance, like who to send in for testing, and the latest ones are from April 15th, and so I have them here to go through in a little bit more detail. The Public Health Ontario and the Ministry of Health is still only recommending testing these following groups that are symptomatic. So that's, of course, we already knew: healthcare workers, caregivers, care providers, first responders, residents of long-term care facilities, and other congregated living settings. But some that have been added are persons living in the same household as a healthcare worker, care provider, or first responder. Other groups that have been added are essential workers and cross-border workers. And we've already gone through what the symptoms are, but they've written that the most common symptoms are fever, and actually cough is the most common one, a dry cough, fever, and shortness of breath. However, if anyone has any of these symptoms, and they just released a new document, if they have two of these other symptoms, like a sore throat, runny nose, and so forth, those are considered symptoms. And if they meet those criteria, and at those groups, those are who to send in for testing. The Ontario government is not recommending routine testing of asymptomatic cases, but to consider testing asymptomatic cases if they fall into any of these groups. And in fact, if a long-term care facility is having an outbreak, Toronto Public Health or the Public Health themselves are going in and arranging the testing of all the asymptomatic cases. In terms of COVID-19 patient assessment tools, this is the one I really like. It's from the OMA. I find it quite simple, and maybe Jane, you used one like this, where if a patient is symptomatic, you ask about their symptoms, you consider whether they're severe. If they are severe, you send them to the emergency department, especially if they're short of breath and having difficulty breathing. If their symptoms are mild, and they meet one of the groups that we talked about on the prior slide, then you send them in to get tested, and to a COVID assessment center. If they do not meet one of those groups, then you have to walk them through how to self-isolate. And so I put up this slide here of the handout I use on how to self-isolate. You can get it from the Public Health Ontario website. I have the link in my references, but it goes through very simply how to self-isolate for patients. And in brief, you tell the patient they have to self-isolate in their house for 14 days from the symptoms starting. And if they're still symptomatic at the 14-day mark, they need to continue isolation. So 14 days and 48 hours after their symptoms go away. This is probably the most common tool being used right now. I'm not sure if you've seen it. It was published in BMJ Open, and it's called COVID-19, a remote assessment in primary care. And it's to walk people through how to do an assessment over the phone or remotely. And they use a lot of the same steps we've gone through, setting up and connecting to your virtual medium, getting started, taking a history, the examination, and then the decision and action. And some of the tips I thought that were really useful is they said that most patients with COVID-19 can be managed remotely or by phone. And remote, and they go over some tips on how to do a remote assessment of breathlessness. So asking, for example, like, how is your breathing? Are you breathing faster or harder? Are there activities or things you could do before, but that you can't do because of your breathlessness? They've also pointed out some red flags, like difficulty breathing, chest pain, decreased urine output, confusion, blue lips, hemoptysis, and if people have any of those, to send patients to the emergency department. I found some really good COVID-19 patient handouts, and I know there's other ones out there, but these are the ones that I found. I'm not sure if everybody knows, but Up to Date right now is giving guest passes and complimentary passes and access. And they actually just sent out an email that they're going to be extending the complimentary access till May 31st. And that's the website. So if you go to that website, you can get a complimentary username and password until May 31st. And so, for example, they have this patient education handout on coronavirus disease 2019, and it comes in a whole bunch of different languages. So I downloaded that and I found that useful. A Well Living House in Ontario, who's led by Janet Smiley's group, has put out some some patient handouts that are Indigenous specific. So they have a few, so you should check out their website, but this is one on COVID-19 symptoms and testing information. And I just thought that it was very beautiful, and I'm using it actually with all my patients. The Royal College of Physicians and Surgeons of Canada, in partnership with the Canadian Medical Association and the Canadian Family Practice College, has put this website together, www.covidquestions.ca. It looks like this, and I find it really great to direct patients here if they have a lot of questions. And for example, you have to get to your next call with another patient, you can direct them to this website to answer a lot of the questions, and the answers might be better than what you can potentially provide. What I think are the most important points to leave patients with is really, like, I don't think we have to do this much anymore, but early on, reinforcing that COVID-19 is a real pandemic, and it's important to take it seriously. The most important thing to do is the physical distancing, and a lot of reassuring that Ontario and Canada is doing a good job, and that remembering that most of the cases are mild. And if someone does have moderate to severe symptoms, especially shortness of breath, counseling them to go to the emergency department, noting what the high risk factors are, like older age and the other comorbidities, reviewing if they're doing okay, what about their anxiety, what about their fears, and reassuring them and coming up and maybe helping them with some techniques for handling that, and reassuring them that you're here for them. And actually, with one of my patients who was very anxious, I used this tool, and Allison actually brought this up at an earlier session, and walking someone through about what are the different items that they can control. Like, they can control their positive attitude, they can control their own social distancing, and what they can't control other people's social distancing, or they can't control what's going to happen with the pandemic, and that they have to let go of those things if they can. And here are the references. Thank you very much.